Hello, everyone, and welcome to our podcast today, where we will bring the connection between the laboratory and the clinic together to discuss how the latest generation of testing can help identify pathogens, to get a diagnosis, and harnessing potential partnerships between the laboratory professionals and infectious disease providers. It is my distinct pleasure today to welcome Dr. Mike Lapasato. He is currently the chairman at UTMB Pathology, and I know he has a past that I'm going to ask him to talk about a little bit today with Vanderbilt and some other kind of past work that has got us to this podcast today. So welcome, Mike, to the
Thank
podcast.
you.
You are our inaugural guest, and it is truly an honor to have you on with us today.
Well, I'm equally delighted.
Great. So let's get started. I want to talk to you in the beginning here about how you first got interested in this concept of diagnostic management and kind of your history with it.
Sure. I was doing a residency at Washington University. I'd graduated from Johns Hopkins. I was an MD PhD student, and I was interested in a specialty that bridged the gap between technical things, as in laboratory medicine, and clinical things. So there I was in laboratory medicine in a program that was considered one of the most advanced programs for someone like me. And what I was shocked to learn is how much help everybody needed in selecting lab tests. There was a fellow who was considered to be the best internal medicine resident, and he had an 8-year-old boy he was taking care of, and he needed a tonsillectomy. He did some preliminary tests, one of which was a coagulation test called a PTT, and it was elevated. This is 1984. And so I got a call from him because he knew me. And he said, I want to give this little boy a unit of fresh frozen plasma to normalize his PTT. And I said, Clay, do you know why his PTT is prolonged? Because you might not need to give it. And let me tell you, 1 out of 20 bags has HIV in it. And we don't know what to do. If people get infected, they just die. And I said, you really want to take a chance with this little boy? And he said, I would love to not take the chance, but who in the laboratory can I routinely call to say, what do I do with a prolonged PTT? Because I don't know. And I thought about it, and I said, in med school, we probably got 90 seconds on the PTT. And then there were 100 other tests. And then I said, by the way, do you know what to do with a positive anti-nuclear antibody test? And he said, no clue. And I said, so all those autoimmune disorders, they're a mystery too? And he said, really, we are in a system right now. Remember, it's 1984. Is it worse now? Where we just guess. And I thought, you are guessing and you are costing people their lives. That really was the example. That was all I needed. And that made me say, we need to be involved as experts that help people pick the right tests. And then I thought radiology does, and they interpret the test. So why are we just giving you a result like a PTT of 60 and asking you to interpret it? And what about anatomic pathology? We don't hand you back the breast biopsy and say, figure it out, give me a call if you don't know it. So I thought, oh boy, an entire specialty has to develop. So that was the need question. The part we're going to get into, I hope, is the potential solution question.
Right. Thank you. It takes me back a little bit too, because I was not to date us here, but I was a junior or senior in high school in 1984, and HIV was blowing up all around young people, and it was scary. And just to think about just that in the midst of picking the right test and predicting what to do with respect to outcomes. So can you talk a little bit about, so that was the story, the impetus that turned on your light bulb, I'm sure.
Yep.
Can you talk a little bit about that diagnostic management team development,
Sure.
even if you bring in your own UTMB program as a
No, I'm happy to tell you. So there I was at Washington University as a resident, working at Barnes Hospital. It's always one of these hospitals that makes the U.S. News and World Report honor roll, as was Hopkins. And so I got my first job at the University of Pennsylvania. And as a lab director, I wanted to not only give the coagulation test results, make sure that they were accurate, but I also wanted to interpret the test results, look at the medical record. So I started doing it. And I didn't ask permission. I just did it because it was the right thing to do.
Right.
Boy, was it successful. So people in all these specialties in internal medicine said, oh my gosh, like I had no idea this was von Willebrand's disease. And they told me what tests to do, and they told me what the answers meant. And the chief of hematology at that time came to me and said, stop doing this. And I said, why? He said, you're getting the diagnosis too fast. I said, isn't that a good thing? He said it would be, except now they don't need the hematology fellow and I can't pay them. So he said, you're wrecking the hematology program. He was the professor and I was new on the job. So you can guess what happened. We stopped, except now I knew how to get it done and I knew what the reception would be. So I stayed at Penn for 4 years. After that, I went to the Mass General. This time I was chief of laboratory medicine. We just started doing it after about 2 years of getting our ducks in a row. And it was a huge hit. 2,000 Harvard doctors who said, what a good idea. There were 4 people who actually consulted from internal medicine on this, but they only consulted for the patients that they saw. We took every PT and PTT and told everybody what the diagnosis was. So if some surgeon didn't get a hematology consult, then that poor patient went to surgery and bled unnecessarily. So what happened is the 4 people tried to shut it down, but it was too late. We were clearly making too big an impact. By that time, the residents were walking around with an index card and they said, oh, look, here's what the coag people told us to do. And they had a checklist and they said, you can't get rid of that. So there we were with just coag, and that was 1995. And then it spread from there.
Standing. I know I often talk about this as a chair of a medical lab science program, and I know you're working closely with that program as well as the DCLS program there at UTMB Galveston. But I always talk about how, it, and this has been true in my career path as well. When you're first starting and you're starting to learn your expertise, and then there's this time period where you sometimes do have to wait, like you have to get to the potential of having the responsibility to influence decision making, right? So it's kind of interesting you mentioned it, even as an MD PhD, that you had to kind of wait that moment, but that you kept that idea. That's really, really critical. Can you talk a little bit about your program and
Sure.
doing so, maybe what you see with respect to the graduates that finish that program, and kind of, where do you see them? I know it's happening. It's really exciting. We see some of these DCLS and other types of graduates ending up as lab directors now and faculty and obviously in the trenches of healthcare. But can you give some of your kind of experiences with that?
Sure. So you got the story from inception in 84 up to about 95 when we started. So obviously we did all this manually. It was brute force. It's look at the record, resident looks at the record, and we had up to 30 or 40 cases a day just for coagulation. So it took a long time, and it took 2 hours to sign out all the cases. So we had made something work, but we couldn't make it work outside our own institution. Not the least of which, by 97 or 98, I was giving talks on diagnostic management teams with the assumption that if you have anatomic pathologists who look at just GI cases or just head and neck cases, and you have radiologists who are, the people who deal with neuroradiology, it's just the head and they're. So I said, why can't we do this in laboratory medicine? You know what we need to do? We need to have people who would be experts in laboratory medicine and do what anatomic pathology does in every major academic medical center. And everybody said, that won't work. And what was the big reason? And it was legitimate, I think. They said the codes that exist for payment do not allow us to get paid for going down to the emergency room, telling people why somebody's bleeding, saving their life, we're going to get $25. On the other hand, if I do something simple, like sign out a hernia sac, which isn't going to matter a hill of beans on clinical outcome, I get paid hundreds of dollars. So then we said, okay, that's a real problem. And that's why when I was at Mass General till 2008, it pretty much just stayed as coagulation as an expert team, and we did everything manually. So we really started to think about it bigger. I went to Vanderbilt as an executive vice chair, now interested in moving up to be more influential and make some of these things happen. So when I went to Vanderbilt, we created about 5 diagnostic management teams, one for heme path to put molecular and flow and all the microscopic work together. That worked great. And we did a few others as well. And they invested some money in us so we could do the cases better. But we still had a problem with dissemination of it. So I was still working at the Mass General. We set it up there. It was still working at Vanderbilt. I was there. But how do we make it go anywhere else? And we realized the biggest problem was the pathologist because of the insurance payment. So it was about that time that intermediate care providers were showing up everywhere. I mean, physician's assistants now being called physician's associates, the nurse practitioner. We realized that medicine is complicated now. And so it takes a bigger team. So the question is, we're training people in laboratory science. Couldn't we make as a first step the generation of somebody who could work as an intermediate care provider? That is, look at the 25 or 30 coag cases and say, okay, I think this is von Willebrand's disease. This is hypercoagulability with factor V Leiden, ... They're the communicators. They're the ones who say, at 2 o'clock in the afternoon with rounds at 4, I talk to the doc, the patient's going to cardiac surgery, the HIT test is positive. What are we going to do? So when we got to rounds, then we had residents do as much as they could. The trouble is, it was clear we needed an entire new body of experts to be on the team. So at about that time, maybe slightly before Vanderbilt, it was a little after 2000, I was stopped on the sidewalk by somebody who ran a clinical laboratory sciences program. And her name was Paula Garrett. And she asked me, we would like to start a doctoral degree in clinical lab sciences that is roughly equivalent to the doctoral degree in pharmacy. So I said, wow, what a good idea. And in about 5 seconds, I thought, my goodness, that's the team. These are the people who could do what needs to be done. Also about that time, the National Academy of Medicine started to look at how many people died because there was a diagnostic error. You come in, you're short of breath. They say you have asthma. They give you a nebulizer. It turns out you have a clot in your lung. You got the wrong medicine. The clot gets bigger, you die. Count that, right? So it turns out the conclusion we made, I was on the 21-member committee, every adult American was the victim of at least one diagnostic error. I counted mine because I know medicine, and I've been the victim of 10. So people are out there getting the wrong diagnoses, and we can do something about it if we make an efficient system. So I get now, after 6 years at Vanderbilt, to the University of Texas, now finally as a chair. And fortunately, we have a really great clinical laboratory sciences program in our School of Health Professions. And I was in a meeting where we started to discuss the possibilities for how we could collaborate. And this doctorate in clinical laboratory sciences arose again. Now, this is a long time from the sidewalk conversation in Chicago. But I said, are you kidding? I've actually been thinking about this for about a decade. I think I know the curriculum. I'm going to get pathologists to do the appropriate teaching, because this is not a matter of here's how to do the test.
Right.
Or troponin. What we're going to do is we are going to train people to talk to a cardiac surgeon about the need for getting a troponin test and how it might be altered by an incision in myocardial tissue so that it's not a heart attack. And that is a totally different thing.
Right.
And I said, to do that, we got to put them out in clinical services. I mean, we have to have an organized way to put them into the ICU. Have them work like a medical student. You see the patient, you understand the patient suffering, you understand the clinical need. So we put together a program which we think is unique because it has within it the interpretation experience. Here's your 30 co-ed cases. This is what we're doing. And you're also going out into seeing the clinical patients. And that's a hard thing to put together. We understood, but we also understood that we had a unique opportunity. And we were passionately interested, both sides. So we spent 2 or 3 years. We put together a program for the doctorate in clinical laboratory sciences. And from the time we started until now, we've graduated more than 30-ish people, maybe about 35 people. And about half of them have stayed in this zone of working what is now called a diagnostic management team. And the other half have gone on to be other important things, full laboratory directors in places. And really the most exciting thing that I think was really validating is 2 of our graduates are now a member of the Harvard faculty.
Right.
Now that is so cool. And
I actually met one of them last week at COLA. He was on a panel, and it was a pleasure and an honor to meet him. He spoke so highly of your program, and it's just such an interesting area. And I know we've talked about this before, that it's this long idea that's coming to fruition. So I'm so excited to kind of meet some of your alumni, and of course for the audience, there's a program at Rutgers as well as at Kansas Medical School. So we have
and they're
3
going to grow.
programs. Yeah, hopefully
There
we'll
will
have
be
more
more
across the West.
So we need, this is a whole body of practitioners that we need. It's interesting that we started with the pot being empty. There are not many times when you look at a specialty and you say, actually, there's nobody in it. Like, who's supposed to teach it? What's the curriculum supposed to be? So when you look at, I don't know, rheumatology, when did that get figured out? That was probably about 1930, right? So here we are somewhere in the 2010s trying to figure out, how are we going to educate these people? What do they have to know? What will be their role? And so, as you just said, Rodney, I got to tell you, we're really proud of the graduates, and they stayed connected to us. And it won't be long until there will be dozens of examples. And I think we've hit the sweet spot, really, because there are other ways to be a lab director, but none of them involve this much clinical training.
Right.
And what's really needed is the clinical training. That is, having a lab director who runs a research lab and gets an R01 is a good thing. However, that does not solve the problem of somebody's going to surgery,
right,
and they're positive for heparin-induced thrombocytopenia.
Right. I know I've been fascinated. I've seen some of your talks. I know you've spoken in Texas several times at our state organization, of course, nationally. And you always brought up that, you're living in your own experiences of 10 diagnostic errors. And I find that fascinating, because when I'm talking to bachelor's level medical lab science students and talking about this pathway, they get really excited, because I think you're right about the sweet spot. Because what's happening in my estimation is that now we have a totally different generation of MLS professionals, MLTs, and others that are coming into this, and they want to be engaged.
Yes, they do.
They know that they can be the experts on, as the front end. And of course, it's going to take some massive training to kind of know all those conflicts with different drugs, different conditions, and things like that. But on the back end, right, is interpreting of the information that comes out of the bazillion molecular tests that we have now.
And just remember, you got to jump in. People have asked me, when you started, how much did you know?
Right.
And I said, well, let's see. When I went to the first job at the University of Pennsylvania, I spent 3 years in laboratory medicine, and the last year was all coagulation. And I said, I probably did 20 coag conferences with 2 cases per conference. So that meant that I did 40 cases. And by now, I can tell you, I've signed out over 50,000 cases. Oh. So really, once you jump in to your area and you start gaining expertise, you begin to know everything about the thyroid or rheumatology or whatever autoimmune disease you have. So I think just giving people the idea in the CLS programs that their knowledge is going to expand to the point where they actually are going to be the expert.
Right.
in their hospital for that diagnostic area, that should give them a feeling of indispensability.
Right, right. I mean, I know we're preaching to the choir, but I mean, even in my own experience, and I know you've experienced this I'm a virologist, a microbiologist at heart, and a molecular person. And so even COVID kind
Oh,
of turned me into a passionate advocate of owning. I keep saying this out loud at conferences: own your expertise. Don't be afraid to make some mistakes, and get in there and roll your sleeves up, because the more you do that, the more you're valued. And you've got to get out of that lab. You've got to get into some of these opportunities where people understand us and our values. So I really appreciate your commentary on this subject.